rapid access to comprehensive oncology data, and survival analysis. This is the Enko Toolkit.
You're in clinic, the clock's ticking. You've got a patient with an indeterminate pulmonary nodule, and you have to make the call. Malignancy risk versus an invasive procedure, and you've got minutes to do it.
So think about it. All that time you used to spend digging through guidelines, manually calculating scores, what if you could compress all of that down to seconds? That's what we're talking about here. Instant, streamlined, evidence-based risk assessment, right at the point of care.
Okay, so here's how we're going to break this down. First, we'll tackle that busy clinician's dilemma. Then, we'll get into the foundations, the core prediction models. After that, we'll see the instant risk assessment in action, look at the transparent logic, no black boxes here, and finally, see how this all connects from clinical data right into research.
Right, let's dive in. Before we even click a single button in the software, it is absolutely crucial we talk about the science underneath it all. I mean, this isn't just some magic algorithm. This entire tool is anchored in the validated prediction models that you and I already know and trust from the literature.
So what's the fundamental problem we're trying to solve here? It really all boils down to one question. How do we triage these solitary pulmonary nodules safely and efficiently? Well, this panel tackles that head-on by integrating 3 key validated models to stratify that risk. And you already know the guidelines. We're talking BTS, Fleischner, that has synthesized risk over 10%. That's our typical threshold, right? It's what tells us, okay, it's time to investigate further.
Okay, first up, let's talk about the classic, the Mayo Clinic model. This is really the workhorse, our go-to for estimating the pretest probability of malignancy, specifically in those incidentally detected solid nodules. And it's using all the factors we're used to looking at: age, smoking history, any prior cancer, and of course the nodule characteristics, diameter, spiculation, and whether it's in an upper lobe.
And this is where the rubber meets the road. Take a look at this table. This is how those inputs translate directly into clinical action. You see a low risk, less than 5%, we're probably thinking surveillance. It falls in that big intermediate bucket, 5 to 65%. Okay, time for more investigation. And if it's high risk over 65%, we're likely heading towards resection.
All right, next we have the Brock model, also known as the PanCan model. Now this one really shines where the Mayo model is less suited. We're talking about subsolid nodules and those lesions we pick up during screening. It brings in some different factors, things that aren't in the Mayo model, like the patient's sex, a family history of lung cancer, and the presence of emphysema. And if you look at its risk tiers here on the table, you'll notice it's stratified a bit differently. The Brock model gives us this very low risk category, under 1%, which is super helpful because it might mean no routine follow-up is even needed. The key action threshold moves to 10%. So if you're between 1 and 10%, you're looking at a surveillance CT. But anything over that 10% mark, that's our trigger to start a more intensive investigation.
And that brings us to our third pillar, the Herder model. Now this one's different. It's not a pretest assessment. Think of it more as a powerful refiner. It takes a pretest probability, usually from the Mayo score, and then it layers on top the metabolic activity from an FDG PET scan to give you a much more definitive post-test probability.
And you can see in the Herder cutoffs right here on this table just how much that PET data sharpens the decision-making. If that post-test probability comes back under 10%, surveillance is the most likely path forward. You've got this intermediate zone from 10 to 70%. That's your biopsy or resection territory. And if you're looking at a high probability, over 70%, well, that's a very strong signal pointing towards resection.
Okay, so we've got these 3 powerful models. How do we bring them all together into something actionable? That's where the unified panel synthesis comes in. This tool is smart. It doesn't just spit out 3 separate scores and leave you to figure it out. It synthesizes them into one single guideline-concordant risk assessment. This is what guides your very next step, and it's built to align perfectly with what Fleischner and BTS guidelines recommend.
All right, so that's the science, the evidence we're building on. Now for the fun part. Let's see how the technology actually puts this into practice and takes us from all those complex inputs to a single actionable result in seconds.
But let's be real. How do you actually juggle all 3 of these complex models? I mean, they all have different variables, different weightings. How do you integrate them instantly with 0 chance of error when you're standing there at the point of care?
Well, it starts right here. You've got this one single streamlined interface. You just plug in the patient and nodule data. Age, smoking history, nodule diameter, type, location, literally every single variable we just talked about for all 3 models gets captured in this one spot. No jumping between calculators. And then, bam, This is the result. The second you're done entering the data, the tool instantly calculates and shows you the Mayo, Brock, and Herter scores all at once. So in the example we're looking at here, you can see it's a low risk across the board. Just 1.9% for Mayo, 1.4% for Brock. This is immediate, parallel processing, and it saves you an incredible amount of time.
Now, that speed is amazing. It's powerful. But for clinicians and researchers, trust is everything. And that brings us to a core principle of this tool: completely transparent logic. We're talking absolutely no black boxes.
We don't believe in black boxes. The math and the reference tables are right here for your review. It's a fundamental philosophy.
And here is exactly how we deliver on that promise. If you look at the results screen, you can click and open up the logic trace. And let me be clear, this is not an approximation. This is the exact logic calculation. It shows you the precise variable weights, the formulas, everything that was used to generate each score. This is what we mean by complete clinical transparency. It lets you verify every single step of the process yourself.
Okay, so this is huge for patient care. But the tool is also designed to do something else. It's designed to build a bridge directly from your point-of-care decisions straight into the world of academic discovery.
So every single one of these calculations can be saved. And as you start to build a cohort of patients, you can then export the entire data set with just one click. What you get is a perfectly structured, flattened CSV file. It's got all the input variables and all the calculated scores, ready to be dropped right into your statistical software for research.
And that simple export function, it's the key that unlocks a really powerful full-circle research workflow. And it all happens right inside the Enko Toolkit ecosystem.
So you take that raw CSV, and the workflow is completely seamless. Step 1, on the left, you bring it into the CSV polisher. This is a huge time saver for cleaning and prepping your data, handling missing values, and so on. Then step 2, on the right, you take that polished file and upload it directly into our survival analysis tool. And just like that, it automates your Kaplan-Meier curves, your log rank tests, your hazard ratio calculations, taking you from raw data to publication-ready insights. So that really leaves us with one final thought. When you have a transparent, evidence-based tool that speeds up complex decisions at the point of care and then creates a direct pipeline from that clinical data into your research, the only question left is, how are you going to use it to accelerate both your clinical practice and your research?